Welcome to MedClinch Academy. So today we are going to have a revision session. I have sampled various nursing questions. So this session we're going to go through each and every question, then we're going to have answers, and I'm going to explain in detail every answer. So first and foremost, I can urge you guys to have a pen and a piece of paper. Each question will take exactly 1 minute. You have to read, analyze, and answer each question. And then when that happens, make sure that you check the progress bar below the screen. You can see a yellow bar progressing. So this yellow bar, once it reaches at the end of the screen, it means that the time has ended. So once you finish, you are allowed to score and mark for yourself. If you score 7 and above, it means that you're doing well. If you score less than 7, it means that you have to put more effort. So I believe that you're going to have an interesting session, and I think we can begin. Well, so this question, it was very interesting, a very good question. I have seen it. So the nurse reviews the electrolyte results of a client with chronic kidney disease and notes that the potassium level is 5.7 millimole per liter. So which patterns will the nurse watch for on the cardiac monitor as a result of the lab values? Select all that apply. So in this question, automatically we know the client has got hyperkalemia. So for those guys who don't know, the normal potassium level is always 3.5 to 5 millimole per liter. So anything above 5 millimole per liter, we call it hyperkalemia. When it's below 3.5, we call it hypokalemia. So from that statement, we can say that this client is hyperkalemic. Now, number two, you have to know the signs of hyperkalemia on the cardiac monitor. So we're going to go through that. So in this question, our answer will be choice C and E. ST depression, this is always seen in hypokalemia. Same applies to prominent U wave. So these two will be seen in hypokalemia. But tall peaked T waves and wide QRS complex, we always see this in hyperkalemia. Let's just have a brief review. Now, we know that in CKD, these clients always have complication like hyperkalemia. It's common to see a CKD client having hyperkalemia, and I've told you guys the normal potassium level is always 3.5 to 5 millimole per liter. So anything above 5 is hyperkalemia. Anything below 3.5 is hypokalemia. Hyper means above, hypo means below. So we have seen this client has hyperkalemia. On EKG, we shall see flat P waves, prolonged PR intervals, wide QRS, and tall peaked T waves. In this screen, you can see I have come up with a diagram that can help us understand this better. So in normal ECG or in normal sinus rhythm, we always have the P, the QRS complex, and the T wave. Now, when there's an abnormality like this, when there's an electrolyte abnormality, we may see some change in the rhythm. For instance, when there's hypokalemia, we tend to see some changes in the T wave. So the T wave may become diphasic. Diphasic means it may become positive and negative, and that tends to be seen in hypokalemia. We always have prominent U waves that tends to appear after the T wave, and also this ST segment, as you can see in the screen, the ST segment is depressed. It's not at the same level. It's depressed. So these are some of the signs of hypokalemia. So hypokalemia, think of the U wave, think of the T wave. T wave may become flattened, it may become diphasic, it may become inverted, and also think of the ST segment. ST segment is this segment here. The ST segment is here, this one here. It may become depressed. On the other hand, when you hear the term hyperkalemia, think of the T wave again. The T wave now here, it will become peaked or tented. Yeah, you can see how tented it is. Looks like a tent. Apart from that, also look at the PR interval. It may become wide, or it also may also lose the P wave. So the P wave number one, the P wave we may lose its the PF may become flattened. Yeah, it may become flat. Another thing that you have to know is that the QRS complex, it will become wider, greater than 0.12 seconds. Yeah. Apart from that, also we may see the sinusoidal waves, the sine waves. So these are some of the things that you have to note when it comes to hyperkalemia. Think of the P wave. The P wave, it may lose its amplitude. It may become flat or flattened. The PR interval may become longer or wide. The QRS complex will become wider, and also the sinusoidal waves may be seen, especially when it becomes more severe. And one thing that I have to note also, when hyperkalemia becomes severe, it may cause some deadly arrhythmias, the likes of the VTAC or the VFib. So you have to be very cautious when you are dealing with such clients. On the other hand, when hypokalemia becomes severe, here we may see a prolonged QU wave. And we know when you have got a prolonged QU interval, we may have uh, the towards the pointes or the polymorphic VTAC may happen when hypokalemia becomes severe. I have a table here that you can see. So you have to differentiate between hypokalemia and hyperkalemia. Number one, in hypokalemia, think of the prominent U wave. U wave tends to happen after the T wave. The T wave, it may flatten, it may become inverted. So you have to check that, or it may become diphasic. Then in terms of ST segment, it may become depressed. There will be a mild depression of the ST segment. The Q interval may become prolonged. And you know, when you have got a prolongation of either the QU interval or the QT interval, we tend to have an abnormal arrhythmia called the torsades de pointes or the polymorphic VTAC. So you have to be very cautious when dealing with clients with hypokalemia. Remember, hypokalemia is potassium level below 3.5 millimole per liter. On the other hand, hyperkalemia, look at the P wave, it may become tall, peaked, and tented. The PR interval may become prolonged. And we know apart from that also, I think there's something that I have to note here. In this first statement, I think there's a confusion here. So it's tall, peaked, tented, uh, T wave, not P wave. Yeah, it's T wave. So I hope you correct that one. So you have got a peaked T wave, not P. It's T wave. Then number two, you'll see a prolonged PR interval. Yeah, and also the P wave may lose its amplitude. It may become flattened. There'll be wide QRS complex. There'll be peaked T waves. After I've said that one, and also as the condition become worse, we may see some sine waves or the sinusoidal waves. So in this slide, note the key differences. But remember, I think here there's an error that you have to correct. So the P wave is not tented, it's the T wave. Please make sure that you don't confuse yourself. This is just a small error in presentation. So I believe you guys have understood that. Now let's go to a question number two. Yes, so question number 2, a student asks the charge nurse how Montelukast work. So which response by the nurse is most appropriate? So this is a very good question. So I think this is a pharmacological question. It's testing our pharmacology knowledge. So you should know, number one, the drug called Montelukast. So what type of drug it is. Apart from that, also you need to know the mechanism of action of Montelukast. So if you look at the choices, choice number A, it relaxes the bronchial smooth muscles by blocking histamine receptor. No, we know that montelukast is not an antihistamine. So choice A will be wrong. Choice B is correct because we know montelukast belongs to a group called the leukotriene receptor antagonist. So it reduces inflammation by inhibiting the leukotriene receptor. So number choice B is actually correct. Choice C, it works as a bronchodilator by stimulating beta 2 receptor in the lung. No, this is wrong. We know that montelukast is not a beta 2 receptor agonist. So that choice C automatically is wrong. And also choice D is also wrong. It decreases mucus production by suppressing the immune system. Montelukast is not an immunosuppressant. So choice D is wrong. Now let's just have a brief explanation on what you have to look for. Now, number one, you have to know the type of montelukast, what type of drug it is. We know from a pharmacology that montelukast is a leukotriene receptor antagonist. I believe you guys in pharmacology, when you looked at the antiasthmatic drugs, you may have been taught montelukast as a drug, what it is, its pharmacodynamic, its pharmacokinetic, its dosage, and also its mechanism of action. So from this question, you just have to know and understand how montelukast works. So we know that it works by blocking leukotrienes, and this by doing this it prevents airway swelling, and it also helps in minimizing the mucus production, and by doing that it will improve breathing. So you have to know the common dosage of montelukast. So from this diagram I just have a type of drug you can see in my screen here. It's always given in combination with levocetirizine hydrochloride. This is an antihistamine. Yeah. So apart from that also, I believe you have to know how it works. I won't go deep, but you just know that this drug is a leukotriene receptor antagonist. You can see in my diagram here, we have got an inflammatory cell like the mast cell releasing the leukotriene. So I won't go deep on how this is being produced, but remember, just like the prostaglandins, they somehow share a path on their production. So that being said, we know that once you release leukotriene, what they do is that they attach themselves on the receptors, which may be found on the bronchial muscles, and once they attach themselves, they will cause bronchoconstriction. So without montelukast, we shall have bronchoconstriction. But when you introduce montelukast, what happens? The montelukast will come and bind to their receptors, and by binding to the receptors, the leukotriene, they will not have somewhere to place or to attach themselves to. So you can see the diagram. You have the montelukast being produced, and here they attach themselves. But here, oops, we can see they don't have their receptor is occupied, so they don't have a place to attach themselves. And so when this happens, they will know the bronchoconstriction won't happen. Yeah, so that's something that you have to know. Other thing that you have to know is that there's something that you have to know is that when aspirin is used, we always have an elevation of leukotriene. Why? It's because they tend to share the same path. You can see in this diagram here, we have got arachidonic acid, or the membrane phospholipid. We have got two pathways, the COX pathway and the LOX pathway. Basically, the two enzymes that are involved in converting this membrane into prostaglandins, and here I've got leukotrienes. So what happens when you use aspirin? Aspirin comes and acts on this pathway, and when you block this pathway, you are going to activate this pathway more, and we shall have an elevation of leukotriene being produced. And we know that once you have got excessive leukotriene being produced, we shall have a lot of bronchoconstriction or airway edema, leading to difficulty in breathing. So that being said, we tend to contraindicate aspirin in asthmatic clients. So when you're told to give a reason behind aspirin contraindication for clients uh, who are asthmatic, you have to know how this happens. Aspirin tends to propagate the formation of leukotrienes. Yeah, so that's something that you have to note. Then, apart from that, also you need to know types of drugs being used as bronchodilators. You have to know those drugs that are used as relievers and those that are used as controllers. So for relievers, these are very good rescue medications. They are always used when there's an exacerbation of bronchoconstriction. And drugs used here are the short-acting ones, like the salbutamol. You've got the short-acting muscarinic agents like the ipratropium bromide. You've got uh, the AP and the MagSafe, these one are always used in severe cases. You can see maybe when there's an anaphylaxis, severe anaphylaxis, we tend to use AP. Or when there's severe asthma exacerbations, we may use the MagSafe. Apart from that, also you need to know the controllers, the corticosteroids, the inhaled ones like the beclometasone, the fluticasone. You need also to know the long-acting beta blockers may be used. The long-acting beta agonist drugs may be used as controllers. We have got the long-acting muscarinic agonist antagonists. You have got the leukotriene receptor antagonist, the likes of Montelukast. I've explained this one. You've got the mast cell stabilizers, the likes of the nedochromyl or the cromolyn sodium. We've got the theophylline and the rest. So you have to know, you have to differentiate the relievers and the controllers. So we shall have a separate topic on asthmatic drugs, and we're going to have an in-depth analysis of the drugs that are used to control or to relieve asthma or bronchoconstriction, that as per se. So I believe you guys have understood that one. So that being said, I want us to go to our next question, question number 3. So question number 3. Question number 3. So a nurse is planning care for a client with COPD and a respiratory tract infection. So which of the following interventions should the nurse include to promote airway clearance? So we have got you have a patient who has got two conditions. He has COPD. We also call this chronic obstructive pulmonary disease, and also the client has got an infection in the respiratory tract. So, so what should the nurse do? Now, one thing that I have to know is that in these conditions, there will be a lot of mucus production, because COPD and respiratory infections tends to cause a lot of air interference by hypersecretion of mucus. Now, that being said, number 8, teach the client passive breathing. Yes, passive breathing tends to help. We know that this type of breathing is whereby you tell the client to inhale slowly through the nose and then to exhale slowly through the tightly packed pursed lips. It tends to help, but in this scenario, I don't think this will help. Encourage the client to increase fluid intake. This is the correct answer. Remember, I've told you that in this condition, we tend to have the hypersecretion of mucus. So one thing they have to know is that this mucus may thicken, obstructing or occluding the airway, and making the client to have dyspnea or difficulty in breathing. So the best way is to thin the mucus, yeah, to promote the to promote the release of mucus through coughing. So the best way is to thin the mucus. Plan alternating periods of activity and rest. Yeah, this one for the activity for the clients with COPD, though we advise them to do exercise, it should be through supervision. Yeah, it should be through maybe we should supervise the exercise, because we don't want to cause a lot of complications for clients with COPD, and this may be done through maybe pulmonary rehab. So this one, in this scenario, is not so much important. Then administer oxygen. Before you administer oxygen, you should look for patent airway, and for this instance, clients may have difficulty breathing because of the thick mucus in the airway. So that is what you should go with. So we know that COPD disease, in COPD, we always have airway limitations through mucus hypersecretions, and a respiratory tract infection can worsen airway inflammation and mucus production, making airway clearance even more difficult. So interventions to promote hydration should be promoted. So promote hydration, number 1. it will help to mobilize secretions, and also it will help to improve ventilation. So these are the essentials that you have to know when dealing with these glands. Now, one thing that you have to know is that in this scenario, you should encourage the glands to increase fluid intake, because we know adequate hydration thins the respiratory secretions, making them easier to expectorate. Then, apart from that, also you should increasing fluid intake is a key intervention in promoting airway clearance, especially when infection increases mucus production. So we know that in every scenario, even before you give the oxygen, you have to ensure that the airway is patent. Yeah. So our key here is airway. We should promote airway clearance, and one of the best ways for clients with COPD, where we know that there's where we know that there's mucus hypersecretion, the best intervention is to promote fluid intake. So that being said, let's move to question number 4. So question number 4, a nurse performs an admission assessment on a client with suspected tuberculosis. So which diagnostic test confirms the diagnosis? So this one, for this question, we should remind ourselves concerning tuberculosis. I believe you guys were taught this either in communicable diseases or in MedSurg. Now, one thing that I have to know, this client, we suspect that this client has got suspected TB. So the best test that we always do that confirms that confirms tuberculosis is the sputum culture. So for this question, our answer is the sputum culture. So let's have a brief explanation now. Sputum culture is always the gold standard for confirming active tuberculosis. So we do an isolation and identification of Mycobacterium tuberculosis, confirms the diagnosis, and allows drug susceptibility testing to guide antimicrobial therapy. So sputum culture tends to show us that we have got an active TB, we have got an active Mycobacterium tuberculosis. So nowadays I've got an advanced test called the Gene Expert, which tends to trace the DNA of the Mycobacterium tuberculosis through the polymerase chain reaction. But for this, we know that sputum culture is the gold standard when it comes to confirm TB. We also have got other ones. So I've explained that this is the sputum culture is very good. It's the gold standard when it comes to confirming active tuberculosis. You collect the sputum culture, you collect the sputum, you process, you inoculate, incubate, then you'll identify the growth of the Mycobacterium tuberculosis. So when it's positive, when the culture is positive, automatically we confirm that this gland has got an active TB. We also have got an X-ray. We know that a chest X-ray may reveal the infiltrates, the cavitary lesions, or other findings that may be suggestive of tuberculosis. But that being said, also the chest X-ray is not definitive of the disease, because there are other diseases, there are other pulmonary diseases that may also manifest with infiltrates or cavities. So that being said, yes, chest X-ray may be used, but it's not confirmatory. Yeah? It just supports the diagnosis. So after doing the culture, we may also do an X-ray just to confirm the pulmonary tuberculosis. So you can see in the diagram here, I've got some cavity. You can see some fibrosis in the image. We also have got a bronchoscopy. So this may be performed when sputum specimen cannot be obtained, but it's not the routine it is not the routine confirmatory test. So tissue or bronchial specimen collected during bronchoscopy still require microbiological testing. So for this one, you just take some sample in the bronchial space and you do an analysis. It may be a tissue. You can do a tissue histology, or you can just confirm, you can take maybe a mucus sample from that area and do a culture. So we still need to do a microbiology or a histology if at all we want to maybe identify a cancer. We also have got tuberculin skin test. This one is very good, but it just tends to show us that there was a previous exposure or to tuberculosis, but does not distinguish between latent and an active disease. So this one just shows that there was an exposure to tuberculosis. I can see how it's being done, but it's also called the Montaux test because it was invented by Charles Montaux, a French scientist. So this is how it's being done. I've explained how a bronchoscopy is being done. It's very good, especially when it comes to to culture or biopsy. When you want to take a sample from the bronchial airway, it's always done as an invasive procedure, but it's not a routine for TB. So that being said, let's proceed to question number 5. Yes, question number 5. Well, so the nurse is reading a physician's progress notes in the documented client's record and reads that the physician has documented insensible fluid loss of approximately 800 mils daily. So the nurse plans to monitor the clients knowing that insensible fluid loss occurs through which type of excretion. Now, there's something called insensible fluid loss and sensible fluid loss. Insensible means unaware. Yeah, you are unaware. So insensible, it means unaware fluid loss, while sensible means aware. For instance, I'm sure you guys, if you want to lose your fluid through urination, you are aware you're losing fluids, yeah? Unless you are, I don't know, unless you have got a kasoro fulani mahali. But if you go to the loo, you know you're going to lose fluids. So that is a sensible fluid loss. But sometimes you can just be seated, maybe in a lecture class or doing work, and you are losing fluids maybe through the skin or through breathing out. When you're exhaling, you somehow to exhale some vapor. So that's what we call the insensible fluid loss. So if you look at the choices here, your urinary output, this is sensible because you know you're aware that you're losing fluids. Wound drainage also, they will be some fluid loss which as a nurse, you're aware that this client is losing fluid during the wound drainage. Whereas the integumentary output here, this is the correct answer because sometimes we lose fluids through our skin and we are unaware. That is what we call an insensible fluid loss. The GI tract, this also is aware because you know if maybe you lose through vomiting or through diarrhea or through defecation, the fluid that you're losing, it's something that we can know that this gland is losing fluids. So just a brief explanation, we know that insensible losses may occur without the person awareness. Insensible losses occur daily through the skin and lungs. Sensible losses are those of which the person is aware, and such as through urination, wound drainage, and gastrointestinal tract losses. As you can see in my diagram here, this client is undergoing some insensible fluid losses. It means the client is not aware. It may be through the skin or through the lungs when the client is exhaling. So some of the strategy when answering this question, number 1, you should note that the subject of the question is insensible fluid loss. Note that urination, wound drainage, and gastrointestinal tract losses are comparable or alike in that they can be measured for accurate output. So for sensible fluid losses, it's something that you can measure as a nurse, but fluid loss through the skin cannot be measured. You just approximate. So that's something that you have to note when it comes to this question. So back to your physiology class, remember what you're taught regarding fluid loss, be it sensible or insensible. So that being said, let us move to question number 6. Yes, question number 6. The nurse is caring for a client who has sustained a myocardial infarction. So, which lab test will be increased that is specific to myocardium damage? So, here our keyword is specific to myocardium damage. So, choice A, we have got creatine kinase MB, also called creatine kinase myocardial band. We've got troponin, creatine kinase, and myoglobin. So, amongst the choices here, our answer will be troponin. So remember, when the myocardium tissue becomes damaged, it tends to release cardiac biomarkers. And amongst the four cardiac biomarkers, the one that is specific to myocardium damage is troponin. So let's have an explanation. Now, as you can see in the screen, we have got these four cardiac biomarkers that are produced when the myocardial cell gets injured. So for troponin, this one is the most specific cardiac biomarker when evaluating a client's myocardial infarction. So it is almost exclusive in cardiac muscle, remains elevated within 3 to 4 hours of myocardial infarction and remain elevated for 3 weeks. So that's what makes troponin the best biomarker, because number one, it's specific to the cardiac muscle. Yeah. Number two is that it remains elevated for a longer period of time. That means that even if the diagnosis is delayed, we can still find the elevation of troponin in blood. They've got the CK, also called the creatine kinase. So this tends to be more exclusive to various tissues because remember, we have got various types of CK isoenzymes. We have got the CK-MM. This one basically is more common when there's a skeletal muscle damage. It can be reflected when there's a skeletal muscle injury. They've got the CK-MB. This one tends to be reflected when there's a damage to the myocardial tissue. That's why, as you can see here, point number 2. So this one here, CKMB, and this one is the same thing. The only advantage when it comes to CKMB is that it can be used for infarction because it tends to normalize quickly than the troponin. Yeah, but remember that CKMB, despite it being more specific to the myocardial tissue, there can be some traces when it comes to skeletal muscle injury. That's why we prefer troponin more. The only time that we shall prefer CKMB is when we suspect reinfarction. For CKBB, also called the brain band, this tends to happen when there's a damage to the brain cells. So that's the difference when it comes to CK and CKMB. For myoglobin, this one has got a very poor specificity because we know that it's majorly elevated when there's a damage to the skeletal muscle. So this one will be reflected when there's a damage to the skeletal muscle injury. Yes, sometimes we can see it when there's a damage to the cardiac muscle cell, but it's more when there's an injury in the skeletal muscle injury. So I have derived a screen, an image that we can see for better understanding. We can see our heart in the diagram here and various biomarkers, cardio biomarkers that are being used. You have got the cardiac troponin, two types, the troponin I and the troponin T. We know this one is the best one because it's specific to the myocardial injury. and it also tends to remain elevated for a longer period of time compared to the other cardiac biomarkers. For the creatine kinase MB, this one, it's specific to the myocardial tissue, but it doesn't extend so long compared to troponin. It returns normal after 2 to 3 days. So we can miss a diagnosis if the client come to the facility late beyond the 3 days, because this level will return to normal, unlike the troponin, which tends to remain elevated for a longer period of time. For the creatine kinase, this one tends to be exclusive. You know that it can also be elevated for when other muscles are damaged, like the skeletal muscles. We may see the CKMM. When the brain is an issue, we may see CKBB and others. So this one tends to be exclusive to other tissues. For myoglobin, I've told you guys that it's the only advantage of myoglobin is that it's the earliest to rise. It's the first to rise, yeah. But the only disadvantage is that it has a poor specificity, because its rise may also reflect an injury to the skeletal muscle, yeah. So it's not specific to the cardiac muscle. We may see it also when there's a skeletal muscle injury. So that being said, we tend to prefer the cardiac troponin. There's a graph here that you can see at one free time how they tend to rise and how they remain elevated for a longer period of time. You can see the troponin I and T tends to remain elevated for a longer period of time, unlike the myoglobin, which tends to return to normal after a short while, same to the CKMB and the CKs. So that's what you should know about cardiac biomarkers. I shall create a mini episode just to have an in-depth analysis of how on the importance of cardiac biomarkers, and why it's crucial for us to do this test when a client has got a myocardial infarction. So that being said, let's just proceed to question number 7. So question number 7. The nurse is caring for a client with the following tracing on the electrocardiogram. So it will be correct for the nurse to document the tracing as. So see the tracing in the exhibit. So you have got a cardiac arrhythmia here that you can see in the diagram. Now we want to identify which type of cardiac arrhythmia is this. So choose A, sinus bradycardia. Choose B, normal sinus rhythm with first degree block. Choose C, atrial flutter, and choose D, atrial fibrillation. So our answer there is atrial fibrillation. So this diagram presents atrial fibrillation. Now, what should you know? Now, when it comes to atrial fibrillation, in the diagram, number 1, there's no discernible P wave. You can't see the P wave, yeah? And the P wave are replaced by the fibrillatory waves. The fibrillatory waves, you can see these waves here. Fibrillatory waves. So that's something that I have to know. So there's no discernible P waves, and the P waves are replaced by the fibrillatory waves. Apart from that, also the rhythm tends to be irregular. You can see the distance between the R waves. This distance here and this here, they're not the same. This is longer than this one here. So the rhythm is irregular. So that's number 2 that you have to know. Number 3, I've got 2 types of atrial fibrillation. There are those ones that can be controlled. Those called controlled are those ones with a heart rate of less than or equal to 100 beats per minute. And those that are uncontrolled are those that have got a heart rate of more than 100 beats per minute. So this is an image of atrial fibrillation. Yeah, so the answer there was atrial fibrillation. But you should note there's a very big similarity with something called the atrial flutter. When it comes to atrial flutter, if you see these waves, the P waves now, there is no discernible P wave, but they're replaced by flutter wave. These are called the flutter waves. They have an appearance of a sawtooth. Yeah, they've got a sawtooth appearance. You can see how they look like. So they've got a sawtooth appearance. If you see a heart rhythm with a sawtooth appearance, it's highly likely that that is an atrial flutter. Apart from that, unlike the AFib, this one it may have a regular rhythm. You can see the distance between the R waves they tend to be the same. Yeah? The distance here and here tend to be the same. So the rhythm here it may be regular or irregular. So that's something that you have to note when it comes to A flutter. So between the two, the AFib and the F flutter, you have to know the management when it comes to managing the two. We know that management tends to be more inclusive. We can have um, them being controlled by medications like you can control the rate by the beta blockers or the calcium channel blockers. You may see the physician using the metoprolol or the verapamil and the diazepam to control the rate. Apart from that, also we tend to have a synchronized cardioversion for such rhythms. But before that, they have to be given an anticoagulant, yeah, because when there's an AFib, the blood tends to be static, and that may lead to thromboembolism or stroke. So that being mentioned, most clients are always under anticoagulants, the likes of warfarin. So that's something I have to note when it comes to A flutter and the AFib. Yeah. So synchronized cardioversion may be used, or the medications like the beta blockers and the calcium channel blockers. Even the digoxin may be used when there's a reduced ejection fraction. We may see digoxin being used. There's other rhythms like the SVT that you have to know. So apart from that, we also have got sinus bradycardia in the choices. So sinus bradycardia basically is just a normal sinus rhythm which is low with a heart rate of less than 60 beats per minute. You can see the heart rate here is 60 beats per minute. How do you calculate a heart rate in an EKG strip? So one thing that you have to know, we've got various methods of finding the heart rate. One of the methods is by counting the R waves. Yeah, in a 6 EKG strip, you can count the R waves and you multiply by 10. Or you can basically count the small boxes. Like in this diagram here, we can count the small boxes between here and here, between the arrows. And if you count that, like for instance, here we've got 1, 2, 3, 4, 5. So these are 5 boxes. 5 times 5, that's 25, 25, 26, 27, 28, 29, 30. So I've got 30 small boxes. So 30 small boxes, you take 1500 divided by 30. So 1500 divided by 30, that gives you around 50. So 50 beats per minute, which is less than 60 beats per minute. So this basically is a sinus bradycardia. It may be normal in athletes, yeah, but you have to note either some medications may cause bradycardia. So if a client has got bradycardia, you have to check at the history. You have to look at the age, or you may also look at is the client an athlete. So some of those factors may contribute to sinus bradycardia. Apart from that, also in the choices we had something called the heart blocks. So the heart blocks, we have got around, let me say, around 3 types. We've got the first degree heart block, the second degree, and the third degree. But when it comes to second degree, we've got 2 types. So for the first degree, one thing that I have to note the difference is that in heart blocks, the PR interval tends to be more than 0.2 seconds or 200 milliseconds. If you take this 200 divided by 1000, it gives you 0.2 seconds. So in first degree, the PR interval basically is the distance from here to here. So this distance here, this is the PR interval. So in first degree heart blocks, the PR interval tends to be more than 0.2 seconds or more than 200 milliseconds. So in first degree heart block, if you see the PR interval across the EKG strip, the PR interval tends to be more than 0.2 seconds. For the second degree type 1, also called the Wenkenbach or the Mobius type 1, here the PR interval tends to increase progressively. You can see here, you can see this distance here. This one is long, longer, longest. So there's that progressive increase in the PR interval, and that tends to happen till we have a scenario whereby the QRS is dropped. So that's what we call the second degree or the Mobius type 1. When it comes to second degree type 2 or the Mobius type 2, here we just have the PR interval is the same, but we will have a sudden drop of the QRS. So the PR interval is the same. You can see here is the same. But here we've got a sudden drop of the QRS. The third degree heart block here, there's no association between the P wave and the QRS. Yeah, there's no relation whatsoever. You can see here the P wave it's on an island, or on the P wave it's on its own. There's no relationship between the P wave and the QRS. So what we're going to do, we're going to create as separate episodes on cardiac arrhythmias. But for now, just know that for heart blocks, I've got various types. I've got the first degree heart block, the second degree heart block, with two types, the Mobius type 1 and the Mobius type 2. We also have got the third degree, also called the complete heart block. Next, so basically this is just an illustration for you to know the various terms when it comes to sinus rhythm. You have to know the intervals and the segments and the waves. For instance, in this diagram here, I've drawn for you the P wave. So the P wave is this one here. The P wave, it tends to represent the atrial depolarization, yeah, or the atrial contraction. We also have got the QRS. The QRS, this one, tends to represent the ventricular depolarization, yeah, or the ventricle contraction. When it comes to T wave tends to represent the ventricular repolarization. So that's something that you have to know when it comes to P, QRS, and the T. Apart from that, also you have to know the segments for the PR segments and the ST segment. So the ST segment is very common. You know the ST segment elevation, the ST segment depression. Just like I've explained in Hypokalemia, we tend to have the ST segment depression. We may also have the ST segment elevation in the MIs. So you have to know the segments, the PR segment, the distance here from here to here. This one here, the green, it represents the PR segment. Apart from that, also you have to know the intervals, like the PR intervals, as I've explained in the heart blocks. So the PR intervals, this distance here, between here to here, this is the PR interval. We have got the QT interval, the distance from here to here. This one here represents the QT interval. So these are the terms that you have to know. When you hear the term PR interval, you have to know the QRS, you have to know the ST segment, the T wave, the R wave. So these are the terms that you have to know when it comes to understanding the cardiac arrhythmias. Then I will create a separate episode on understanding the normal, the EKG rhythms, yeah, both the abnormal ones and the normal ones, like the normal sinus rhythm, the AFib, the F latter, knowing the difference between the two, the PVCs, the PACs, the premature ventricular contractions or the premature atrial contractions, the bundle branches, the right bundle branch and the left bundle branch, the AV blocks, the first AV block, the second AV block, the Mobius type 1, Mobius type 2, and the third AV block or the complete heart block. You've got the VTAC and the VFib, and in the VTAC you have got the monophomic VTAC and the polymorphic VTAC, like the starts the point test. I'm going to explain later. And also you've got the ST elevations. So there are very many rhythms that you have to know. The common ones that that can come in exam or in the NCLEX that you have to know as a nurse or as a student. So that being mentioned, I hope that let us proceed to question number 8. Yes, question number 8. The question is, the nurse is discharging a client with heart failure. So who is prescribed digoxin and furosemide? So you have got a client with two medications, digoxin and furosemide. So which of the following lab tests must the client have monitored due to this combination of prescribed medications? So if a client is on digoxin and furosemide, automatically we know that the lab test that should be monitored here is the serum electrolytes. Yeah, and which electrolyte should be monitored here is the potassium. So, an explanation, we know that when a client is taking digoxin and furosemide, we have to monitor serum potassium. Why? Because the furosemide will lead to hypokalemia. There will be potassium being excreted in urine. And when that happens, when the client has got hypokalemia and the client is on digoxin, hypokalemia will increase the risk of digoxin toxicity. Yeah. So you have to know one thing, that hypokalemia tends to promote the digoxin toxicity. And how does that happen? We all know that we always have the sodium potassium ATPase pump, and digoxin tends to bind on that pump. Yeah. So potassium and digoxin, they always compete in binding for that pump. So when there's less potassium in blood, it means digoxin will have an upper hand in binding to that sodium potassium ATPase pump. And when digoxin binds on the sodium potassium ATPase pump, this will lead to an increase of sodium inside the cell. There will be an increase in intracellular sodium. And when there's an increase in intracellular sodium, what happens? We've got the sodium calcium exchanger. So the sodium calcium exchanger will be ineffective, and that will lead to an increased calcium in the cell. Increased calcium leads to an increased contractility. So automatically we know that when there is less potassium in blood, the digoxin will have an upper hand. Yeah, it's like going to a war with few soldiers. If you go to a war with few soldiers, the soldiers with huge number will always win the war. So the digoxin will have an upper hand because there will be more. They'll have a higher chance of binding to the sodium potassium ATPase pump. So that's the explanation. If you see hypokalemia, think of digoxin toxicity. So if a client is in furosemide and digoxin, we have to check that potassium. So that's what you have to know. Hypokalemia, think of digoxin toxicity. So that being mentioned, let's go to question number 9. So question number 9. So the nurse is caring for a client with the following clinical data. So based on the lab test, which medication will the nurse clarify with the primary healthcare provider prior to administration? So see the exhibit for additional client information. So this is our exhibit here. Sorry guys. I think it's so tiny for you to see, but as you can see in the diagram below, we have got various lab values for sodium, potassium, calcium, BUN, and creatinine. So amongst the values, you have got normal. The sodium level is normal, 145, within the normal range. The potassium is 3.7, is within the normal range of 3.5 to 5. The calcium is within the normal range, is 9.3, and normal is 9 to 10.5. The BUN is 25. The BUN, no, the BUN is elevated. The normal is 10 to 20. So you've got an elevation of BUN. The creatinine also 2.1 milligram. It's elevated a bit, male and female with no, it's elevated. It's 2.1. It's highly is elevated. So the question is, which drug should the nurse clarify with the primary health care provider before administration? So amongst the drugs here, we know the indications. Bupropion is always a very good drug when it comes to major depressive disorder. It's an atypical antidepressant. Clonidine I explained in our hypertensive series. I believe you guys, when you looked at the types of antihypertensives, we said that clonidine belongs to centrally acting alpha 2 adrenergic agonist, same with methyl dopa. So this one is an antihypertensive drug, yeah, but it also has got other indications that we talked about when we looked at that drug. So go and watch our episode. Captopril also explained in our hypertensive series. This one is an ACE inhibitor. Albuterol, this one is a short-acting beta-2 adrenergic agonist. Yeah, very good when it comes to dealing with acute bronchospasm. Now, amongst the choices, there's one drug that tends to reduce the GFR. So the ACE inhibitors, they tend to reduce the GFR, the glomerular filtration rate. And if you reduce the GFR, you're going to it will lead to elevation of waste products, the likes of BON and creatinine. So that being said, our answer here is captopril. So a brief explanation is that if you see the client's lab value, you'll know that you'll see an increased creatinine and the BUN. Yeah. So this high level of creatinine requires the nurse to review the client's current medications that could worsen the creatinine level. We know amongst the drugs, the drug that tends to elevate creatinine level are the ACE inhibitor and captopril, the prils, the enalapril, the captopril. Those ones are the ACE inhibitors, and the ACE inhibitor they tend to elevate the creatinine levels. Yeah, these drugs are very good when it comes to managing the clans with heart failure or hypertension. So we know that this drug tends to be nephroprotective for those clans with kidney issues. This drug tends to be nephroprotective because it reduces the work rate of the kidney. It reduces the GFR. Yeah, but despite it being nephroprotective, it can also become nephrotoxic. Yeah. So that being mentioned, you should monitor. You should monitor the levels of the GFR or the creatinine levels. Yeah. So elevations of the creatinine, especially of this level, require reporting to the primary healthcare provider for further direction. So you don't want to give this drug for a client who has got an elevation of BUN and creatinine. So you have to clarify with the physician before you give this drug. Yeah, we know that if the client has got high blood pressure, there are other drugs that can be used. Yeah, that can be used instead of the captopril. So captopril and the ACE inhibitors and also the losartans, the legs of the angiotensin receptor blockers. These drugs tends to they reduce the GFR, and when you reduce the GFR, you're going to increase the level of creatinine. So you have to get clarification from the physician before you administer that drug. So the BUN and creatinine is concerning. You have to seek clarification from the primary healthcare provider. So that being said, let's move to our final and the last question, question number 10. So question number 10. Question number 10 is, let me take my last point. So the nurse is preparing to administer medications to assigned clients. So which prescription should the nurse clarify with the primary healthcare provider? So A, offering to a client with an INR of 1.8 seconds. Choice B, digoxin to a client with a serum potassium level of 3.1. Choice C, enoxaparin to a client with a platelet count of 155. Choice D, lisinopril to a client with a serum creatinine level of 0.6 milligram per dl. So in these choices, our answer automatically becomes choice B, digoxin to a client with a serum potassium of 3.1. If you're very keen on our previous questions, I told you guys that when it comes to digoxin, you have to look at the potassium levels. And when the potassium is below the normal level, you should not give that digoxin because it may lead to digoxin toxicity. In this scenario, we have got a potassium of 3.1. We know the question has given us a normal potassium level of 3.5 to 5. So anything below 3.5, we call it hypokalemia. Anything above 5, we call it hyperkalemia. And in regards to hypokalemia, I told you guys that when the client has got hypokalemia, you should not give digoxin because digoxin will occupy the majority of the sodium potassium ATPase pump, and that will lead to digoxin toxicity. When it comes to warfarin, we know that when you're doing coagulation studies, we always monitor some of the anticoagulants. If you see in this question, we always use INR to monitor warfarin, but if you look at level here, the client has got INR of 1.8. So there's nothing wrong with this value because we are still targeting, we are targeting the normal value. So there's nothing wrong with this choice A. Choice B, enoxaparin to a client with platelet count of 155. The value is within the normal range, so there's nothing wrong. Lisinopril to a client with a serum creatinine of 0.6. The level is still within the normal range, so there's nothing wrong with choice D. So in our explanation here, as I've told you guys that when it comes to digoxin, you have to look for potassium. When the potassium is below the normal level, you don't want to give that digoxin because it may cause digitalis toxicity. So we have to uphold that drug. For INR, the client's INR is not yet within the therapeutic range, so the client should still administer the warfarin to get the client to a therapeutic range. So the client, you are still targeting the range, so the nurse should just continue giving the warfarin. Remember then, when it comes to NR, the NR may vary depending on the client. For someone who is not taking blood thinners like warfarin, the NR may be about 0.8 to 1.2. But for those clients who are taking warfarin, the target may change, maybe around 2 to 3. So in this instance, the client had 1.8. So we may target the range of 2 to 3. So that being said, there's nothing wrong in this scenario. When it comes to nexoparin is a low weight molecular heparin. In this instance, we know that we should, for this client taking nexoparin, uh, platelet monitoring is required for a client. Why? Because we know this drug tends to cause heparin-induced thrombocytopenia. Thrombocytes are the platelets. So thrombocytopenia, it means low platelets in blood. So when giving this low molecular weight heparin, you have to monitor the platelets to avoid heparin-induced thrombocytopenia. Apart from that, our last choice D, lisinopril, we know is an ACE inhibitor, just like captopril. We know these drugs tend to cause an elevation of creatinine and BUN. So in this instance, we need to monitor the creatinine, but in this question, the creatinine was within the normal range. So there's nothing wrong in this instance. You can still give the drug because the creatinine is still within the normal range. So for this question, the only drug that brings the concern is digoxin in hypokalemia. So that being said, you should you should get clarification from the primary health care provider. So that being mentioned, thank you guys for being patient with us. It's a good session. I actually have noticed that there's good topics. There's many episodes that we can do, and this mini episodes is on various topics that we can discuss together. I've come with around 4 topics that I think we can create a mini episodes on. Please let me know. I've come with 3 mini episodes. Number 1, I think we should discuss hyper and hypokalemia management, signs and symptoms, and how they present in EKG. We can look on that as a different mini episode. I think also you can do a mini episode on cardiac arrhythmias, the likes of atrial fibrillation, the A flutter, the SVT. How do you manage? How do they look on EKG? We can also look on the VTAC, the polymorphic VTAC and the monomorphic VTAC and the ventricular fibrillations. We can also look on the heart blocks, like the first degree heart block, the second degree heart block, and the third degree heart block. We can also look on other abnormal arrhythmias that present on the EKG. Apart from that, also, I think you can look on the cardiac biomarkers. I think that's a very good topic of discussion. We can look on the troponin, how it presents itself, on the likes of the CKMB and the myoglobin. So you can create a mini episode on that. And also, I think lastly, you can do a different mini episode on coagulation studies. So let me know amongst the 4 which one do you think is good for us to do a mini episode on. So thank you for your patience. If you are new to our channel, please support us in our various social media platform. You can get us in our IG page, on TikTok also we are there. You can also find us on X account. We are still trying to create a Facebook account, so with time we'll have a page on Facebook. So we shall have this forum whereby you can just meet, and discuss various topics that can help us improve ourselves, be it if you're a student in nursing exams, end of block exams, end of semester exam, you want to do the NCLEX exam, you want to do NCLEX, yeah, we can just discuss. No one knows more than the other. Even me, I'm trying to learn from you guys. So if you have something that you have listened that is contradictory, let us know, let us discuss, let us do research on these various topics. We shall have questions maybe every week, just a revision platform whereby we revise various units or various topics. So thank you for your patience. Please share our link, click that notification button, so if an episode drops, you are able to know. And I think we shall have a good journey on improving ourselves as nurses or as nursing students. So thank you for your patience. I hope you guys have an amazing day ahead. So thank you guys. So if you've scored, so you can score yourself. If you've scored less than 7, I think you have to put more effort. If you've scored above 7, it means that you are at a good place, but you need to aim for perfection. So you can post your, if it's willingly, you can post your marks on comment section so that I can evaluate ourselves and know on the areas that you can improve on. And also, you can post any topic on the comment section that you want us to discuss. It's a discussion platform. We are going to have various people explaining various topics. Today is me. Next time we shall have a different voice explaining or revising with you guys. So thank you for your patience, and I hope that you're going to grow this platform. So have a nice day ahead. Thank you.